Hi, I'm Dr. Raja Quiller. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my online series of training webinars. In this section, I'm going to be sharing with you a 6-point injection strategy for the chin and jawline contouring using hyaluronic acid dermal fillers. When contouring the lower third of the face, our focus should be to lift the lateral jaw, to give more steepness to the jawline, to reduce the heaviness caused by the inferior prolapse of the buccal and the jowl fat compartments, to extend the chin inferiorly and anteriorly, changes caused by the resorption and remodeling of the mandible, to reduce the appearance of the labiomental crease, which indirectly forces the tip of the chin downwards, and finally, to give a better union at the prejowl sulcus from chin through to jowl. All of these changes result in a correction of the flattening of the jawline to achieve more steepness and obliquity. In terms of our technical strategy, I tend to start with botulinum toxin. The reason for this is the chemodenervation of the lower facial depressor muscles in the lower third of the face promotes a paradoxical elevation through midfacial strengthening. The muscles that are implicated are the mentalis, the DAO, the platysma muscle, and the masseter muscle in those patients with jawline widening. So we assess the orbicularis oris in animation, ask the patient to kiss and relax, and kiss and hold. We can see the early formation of perioral rhytids and relax, which we can treat with small doses of botulinum toxin, 1 unit and 1 unit, and kiss and relax. Similarly, we can treat the inferior part of orbicularis oris with 1 unit, intradermally with soft diffusion into the upper superficial fibers of orbicularis oris. Now moving on to the mentalis muscle, ask the patient to sulk. We can see that there is an upward rotation of the lip. We can see the chin is shortening and cutaneous attachments of the muscle in the skin. And relax. We know that by weakening the mentalis muscle, we can relax the chin and promote elongation. So sulk and relax. 1 injection point of botulinum toxin, typically 3 to 4 units is sufficient to treat both of the bellies of mentalis muscle. Now we move more laterally in the lower face. We come to the DAO muscle. So sulk, and now a sad face, and relax. The DAO muscle has an insertion into the modiolus at the corner of the mouth. It has a narrow insertion and a wide origin here at the mandible. Of course, it makes sense for the injection to be at the base, at the widest part, to reduce a risk of diffusion into the depressor labii inferioris. 1 to 2 units is normally sufficient in the subcutaneous plane. And now to the platysma muscle. This is a sheet-like muscle which has an origin at the clavicle and an insertion into the SMAS of the lower third of the face. So grimace and relax. Grimace and hold. We can see that the platysma goes into the neck and has an extension through a band in the upper part of the submandibular territory. Relax. We can inject 1 centimeter above the base of the mandible at 1 centimeter intervals, and then grimace, and into the band in 2 points. The rationale for this technique was described by Philip Levy and is described as the Nefertiti technique. By weakening the lower facial depressors in this vector, we allow elevators such as zygomaticus, levator labii superioris, and risorius to become more dominant, paradoxically generating lift and tightening at the jawline. And now moving to the posterior part of the jaw, the masseter muscle. Bite. This is a large muscle of mastication. The anterior border is palpable in bite, and the posterior border extends to the limit of the angle of the mandible. Bite again. So we can demarcate the muscle. Bite. Its anterior and posterior limits. It has an insertion into the zygomatic arch and into the ramus of the mandible. Safe injection of the masseter must respect the parotid duct as it exits and tracks medially. This tends to correspond to the lower alar commissure line, and therefore injection above this area or into this line is not recommended. Weakening of the masseter muscle can take place at 4 points in a trapezius-like shape, 1 point medially, 1 point laterally at the inferior margin, again medial and lateral in the upper pole. These injections must be deep, so we normally recommend a 15mm needle going all the way down to the base of the masseter to avoid any ballooning of deep fibers if we only inject superficial fibers of masseter. So now let's cover the strategic protocol for injection of the chin, prejowl sulcus, and the jawline to generate a vertical elevation of the jaw, an extension of the chin, and removal of the labiomental crease. Position number 1 would start here at the labiomental crease. We know that injection at this point will promote not just correction at the labiomental crease, but also an inferior extension of the chin downwards. It's also important to treat the labiomental crease in its lateral component as it starts to intersect here with the marionette line. It removes the shadow below the lower lip, but it also gives better relationship between the chin and the jowl region. The second injection point takes place at the apex of the mandible. We can inject on the anterior surface of mandible to promote anterior projection, or we can inject at the inferior part of the mandible for an inferior extension. The next position would be at the prejowl sulcus. We can demarcate this by stressing the skin, always injecting anterior to the mandibular retaining ligament to give union between chin and jowl. The final position for jawline contouring is here at the angle of mandible. The injection point corresponds to 1 centimeter superior medial to the angle itself. Of course, this is a female patient. We know that the female chin should be narrower. In fact, the width of the chin should be the same width as the width of the alar base, which also is the same as the intercanthal distance, which is the same width as the distance between medial and lateral canthi. In the male patient, the chin should be slightly broader to give a more square jawline. The male patient injection should be in line with the lateral commissure of the mouth on either side to give flattening and contouring of the jaw. In summary, the treatment strategy starts at the labiomental crease, then to the apex of the chin for an inferior depression as well as an anterior projection. Treatment at the pre-jowl sulcus. And then finally, a lift at the angle of the mandible to give a tightness and more vertical dimension to the chin and jawline. So we begin anterior to the mandibular retaining ligament. This injection is subcutaneous. Moving from lateral to medial. We can see an immediate resolution of the labiomental crease, and at this position towards the midline, we can start to now see an inferior descent of the tip of the chin, because an improvement of surface tension downwards towards the base of the chin. A slight moulding action is sometimes desirable, and we can see now a much better relationship between the lower lip and the chin when compared to the contralateral side. So now we have the resolution of the labiomental crease using Juvederm Volift. We change the product to Juvederm Voluma because we want to have more projection in the anterior and in the vertical dimensions. Now at the base of the chin, we have two options. We can inject on the anterior surface of the mandible to give an anterior projection, or we can inject on the inferior surface of the mandible to give an inferior projection. First, we inject on the anterior surface of the mandible. So through the division of the mentalis muscle, down to the bone, fixing with the non-dominant hand, big aspiration to avoid the marginal mandibular artery, and then gentle extrusion. This area can take larger quantities, up to 0.3 to 0.4 cc. You can see that there is a visible change in the contour of the chin, becoming more sharp and more extended. We mould to conform it to the mandible. And if required, we can inject just at the apex of the chin to give a little more inferior extension. Again, being very careful to aspirate always before injecting. So now we can see the labiomental crease is strong in the vertical and in the horizontal plane when compared to the contralateral side. However, the pre-jowl sulcus is still slightly weak. So we inject here, anterior to the mandibular retaining ligament, and injecting through the skin, and now down to the periosteum. Always aspirating, injection. We're going to elevate to form a small mound, and then we'll conform the product to the tissue through a mould in the anterior direction, because we don't want to add weight to the jowl fat compartment. Now we see a better union between chin and jaw when compared to the contralateral side, where we have slight skin excess and descent compared to this side. So now the final injection for jawline lift is here at the angle of the mandible. We know that a really youthful and beautiful jawline includes better definition here at the angle. The injection point is located 1 centimeter superior medial to the angle itself. We pinch the skin because we want to inject in a subcutaneous level. Flatten our injection angle, and then we can release. Big aspiration, and then slowly inject. Typically, we'd require 0.1 to 0.15 cc. So I take my small bolus of product, and now I'm going to stick the skin in a more superior lateral position onto the ramus of the mandible to give some lift, elevation and tightness across the jawline. On release, we see that there's a much better defined jawline that's become steeper in angle, which also has an influence to the oral commissure. We see elevation here when compared to the other side. Heaviness on the untreated side, improvement in surface tension through the jaw and also the jowl fat. Now, let's inject the lower third of the face with botulinum toxin. We'll be addressing injection of the orbicularis oris muscle, so kiss, relax, and kiss, relax. The aim to resolve the perioral rhytids, but also to give it a degree of eversion to the upper lip. Next point is in the mentalis muscle to stop the upward rotation of this muscle. Sulk, relax, sulk, relax. The next point is in the DAO muscle, the muscle responsible for the descent of the oral corner. Sad face. So, relax. Sad face. Relax. You can see the muscle fibers contracting through this axis, but we inject at the base here as it's the widest part of the muscle. Then into the platysma, 2 injection points, which extend down through the neck. Now to the masseter, we inject deep, 4 points into the body of the masseter muscle. So now let's go through our injection strategy. Injection of orbicularis oris muscle must be intradermal or barely subcutaneous. Each injection point is just 1 unit of Botox. Next, we move to the mentalis muscle. So all the way to the bone. And this is 4 units of Botox. Now we inject the DAO muscle, always injecting in the same orientation as the muscle fiber. This is a subcutaneous injection. And this is 2 units. Now to the platysma. Again, subcutaneous, 2 units, subcutaneous, 2 units. Rotate. And for the bands of the platysma, we pinch the skin, 2 units. And again, pinching the skin and injecting 2 units. And now for the masseter muscle. We inject larger doses in the masseter muscle and we must inject deep. First injection, orientated towards the center of the muscle, is 4 units. Another injection, similarly, at 4 units. 2 smaller doses at the upper pole of the masseter. 3 units each. The effect of injecting botulinum toxin in the lower third of the face is to smooth the perioral rhytids, influence the eversion of the lip, extend the apex of the chin through softening of the mentalis activity, elevate the corner of the mouth through weakening of the depressor effect of the DAO, promote elevation of the lower third of the face by weakening the depressor effect of the platysma muscle, both in the supramandibular portion and within the neck. And finally, slimming of the lateral part of the jawline through masseter wasting, especially in those patients that suffer with bruxism or pain or mastication disorders.